Hello, my name is Cheryl Coletti, and I'm a registered nurse with a master's in nursing education and the clinical program manager at South Shore University Hospital Cath Lab. I've worked in healthcare for over 20 years, beginning in EMS, then became an emergency room nurse, and then transferring into cardiology. Thank you to the American Heart Association for letting me contribute to this chest pain toolkit, and I hope this information is helpful in reaching your facility goals. I have no disclosures. And for this presentation, I'm going to briefly discuss South Shore's program background and then the project pillars for this initiative. But I cannot stress the importance of collaboration. We would have never been able to achieve these results without the partnership and communication between the emergency department and the cath lab. A bit of our program background. The best practice goal is to obtain a 12-lead ECG for all patients presenting with a cardiac-related chief complaint within 10 minutes upon arrival to the emergency department. At South Shore, historically, we had very poor compliance with this. Our average door-to-ECG time hovered around 11 to 12 minutes, and for the past couple years, our compliance rates were in the 60s. In 2020, the American Heart Association updated criteria for mission lifeline recognition, and door to ECG, which had previously been a quality measure, would now be included as an achievement measure. We would need to achieve and then maintain 75% compliance to keep our gold status. The timing of this project's kickoff led to some significant challenges. The COVID pandemic began in 2020, and like many hospitals, we had significant staff turnover, both at the bedside and within administration. Our ED volume also continued to increase year over year. That increased volume, coupled with newer and inexperienced team members, posed significant challenges in this project. But with the initiatives we put in place, we were able to make significant improvements to our door to ECG compliance, both increasing compliance rates and decreasing the amount of time of arrival to ECG. We still have fallouts, but we also now have a structured process and open communication between the departments. We're at the point now of, instead of having to make these broad process improvements and overhaul across the board, we address our fallouts on a case-by-case basis to figure out the individual circumstances leading up to the fallout. And let's talk about the initiatives and how we achieve these results. Our team focused on three main pillars: education, utilizing targeted data, and raising awareness. Nursing and patient care support are the two main teams who drive this initiative. We needed to connect with staff at the bedside to gain a better perspective and then build our education around their needs. We held focus groups with the nurses and the nurses' aides. And these were not structured meetings, it was an open forum, but speaking directly with the staff provided valuable information of what was happening at the bedside and then enabled us to tailor our education to meet the unit needs. It was also important to keep evolving our approach to education and keep it dynamic. Recently, we started running mock code STEMI drills with our Systems Center for Learning and Innovation. We run through code STEMIs on site using a standardized patient and a simulation mannequin, and then have a full debrief with the team to discuss our opportunities. One common theme we heard in the focus groups was a desire to understand the rationale behind these program goals and then a need for quick reference tools. The emergency department leadership started their ED fellowship program for the new hire nurses, and this is an intensive orientation program for the new graduates hired directly to the ER. A Mission Lifeline AMI care lecture was included in their classroom time to explain in detail the program, why our hospital participates, and then review patient outcomes related to STEMI care. In these lectures, we talk about AMI pathophysiology, nursing care, and key points of documentation. Most recently, we've added a cath lab observation day to the new hires to help solidify our goals and build camaraderie between the units. We've also created several quick reference guides and tools. We created an ECG cheat card. We used the picture provided by the American Heart Association as a quick reference tool for signs and symptoms of a heart attack, and created our own STEMI patient prep checklist. A big part of education was involving the registration staff. When patients arrive through walk-in triage, they're quick regged first and then they see the triage nurse. This was originally done to help with throughput in the triage area, but it ended up negatively impacting the door to ECG time. I met with the registration leadership and we created packets that were rolled out in meetings and huddles. The team was not asked to do anything clinical, but if a patient directly stated they were having chest pain, shortness of breath, or any related symptom, the registrar was to alert the triage nurse immediately. But it was very important to empower all team members and help them to understand the impact that they have on the patient, regardless if they're directly doing patient care. The next project pillar was utilizing targeted data. At first, each door to ECG fallout on our STEMIs were reviewed individually. It was helpful, but there were some problems with that initial approach. The first being it was very time consuming, and all the discussions were held after the fallout. So, you know the phrase hindsight is 2020? It was very easy for us to identify what went wrong afterwards, but it wasn't helping us improve care. We were collecting a lot of information, but it really wasn't helping us get ahead of that curve. And then secondly, we're a high volume facility, but we have relatively few STEMIs compared with the number of patients who arrive with cardiac related chief complaints. And with that N being so small, it was difficult for us to identify trends in the fallouts. We really needed to target our efforts. I worked with one of our senior managers to create a door to ECG scorecard. Every day, I get the previous day's DOH log, pick out all the potential cardiac patients who arrive through walk in, not just the ones who ruled in with AMI, and review the chart for a door to ECG time. The ones who exceed the 10-minute guideline get further broken down by age, gender, time of arrival, ethnicity, and chief complaint. This is all organized through an Excel sheet with pivots and generates a scorecard that I present at our ED committee meeting, cardiology quality, and our STEMI champion meetings. And this data was really helpful to understand the trends around our fallouts. So just going back to our scorecard, for example, that precise data we collected, we found that we were primarily struggling with middle-aged female patients with a chief complaint of chest pain. When we brought this information back to the team through the champion meetings and our focus groups, we found out that the biggest reason was privacy. We simply didn't have enough bed spots to accommodate an ECG on our female patients. We brought this up through leadership, and they were able to create more bed spots with privacy screens. Another example was the time of day. We found out that we were falling out primarily between 3 p.m. to 11 p.m., and that's our hotspot for shift change and meal breaks. Again, we brought that information through ED leadership, and they were able to rework the schedule so there's always an aide assigned to walk in for our ECGs. And most recently, a second triage station was set up to help accommodate during those high volume times. So the third pillar being raising awareness. Those smaller meetings and individual discussions became the foundation of our STEMI champion committee. Previously, we had departmental meetings, but we didn't have a place where cardiology and emergency care met to discuss care goals and the quality initiatives specific to AMI care. The STEMI champions are open to everyone who interacts with the patient, with the thought that everyone has an impact on our outcome, and hearing everyone's perspective helps us work better together for our patients. The champion committee has been helpful in bringing team members together, raising awareness of issues and problem solving. For example, we recently had a fallout where the patient was Spanish speaking, but there was difficulty finding the interpreter iPad. The case was reviewed, and our patient experience and language access team presented at our next champion meeting, reviewed all the resources available, where to find an equipment, and how to access interpreter services in an emergency. We also recently created the Mission Lifeline for Leadership Committee. This group is comprised of directors, unit managers, and physicians from both the ED and cath lab, along with a representative from our quality department. This group meets quarterly to keep leadership up to date with our most current program standings, our stretch goals, and our project process. I'm sorry. One challenge connecting with the bedside staff is the rotating schedules, like daytime versus nighttime shifts, and it isn't always possible to coordinate meeting times. All data, meeting minutes, and updates get posted in our STEMI encasement outside the ED and cath lab break rooms to help raise program awareness. We also have a running Teams chat for our STEMI champions, offering another outlet to connect with the champions in between meetings. And most recently, we created a STEMI feedback survey accessible by QR code. The goal here is to have a convenient way for all team members to provide feedback or ask questions about the case. And as our program enters its second decade, we continue looking for ways to keep involvement up. In 2024, we heavily turned our attention to community outreach and education events. We've partnered with local libraries, community centers, and youth groups. We've opened up our monthly cath education conference to the emergency department and encouraged team members to participate in observation days in the cath lab. And while these events are not centered specifically around door to ECG, bringing the teams together for fun activities helps unify us and solidify our team goals. And it really has become important for our overall success. Thank you.